Well, now, without any further ado, on to the main event today, and that is Networks, the Future of Healthcare, with all the massive consolidation that is going on between insurance companies, hospital groups, independent practices being bought and merged into other ones. There's just an awful lot of consolidation. And Ken Peach is an absolute wonderful resource that we have here. He is the Executive Director of the Health Council of East Central Florida. And that is the planning agency for Orlando and the Space Coast. Before joining the Health Council in December of 2010, he ran a medical practice business, developing company and health insurance agency, and he has spent many, many years as a hospital administrator with health systems and senior living facilities, and he was even, for 2 years, the American Hospital Association Regional Executive for Florida, for Puerto Rico, and the Vice President of Integrated Delivery Systems with the Florida Hospital Association. And I've had the pleasure of working with him for a number of those years at various different media outlets that I have worked with over the years in Central Florida as well. So I love the fact that we have a great relationship with Ken Peach and his ability to kind of let us take a peek into the future of healthcare delivery for Central Florida. Thank you, Ken.
Very good. Thank you, Dorothy. Thank you. Thank you. Nothing like leaving the clicker on the table before you get started. Sometimes it helps to look back. We did a strategic scenario planning retreat back around 1999 with one of the health systems, and there was a lot of suspicion that, okay, well, what are we talking about? Is this going to be something we can take home and use? Are we going to be able to put this in place in the business? And we said, sure, let's go ahead and we'll show you. And we took 10 years back to about 1989, 1990, and we said, okay, where's the internet? Where are cell phones? And people realized very, very quickly that in that 10-year period, how things had changed. Well, in many ways, we tend to forget, I think sometimes, where have we come from? What's occurred that set in motion what we're going to talk about today, and in this particular case, that's networks. So the first thing, if you take a look, have there been other networks? Yes. I helped to do the first joint venture between a for-profit and not-for-profit hospital in the U.S. That was South Seminole Hospital, a for-profit, joining into Orlando Health. And that took about 18 months behind the scenes to negotiate and put that deal together. Once it was done, within 18 months, we had a formation of 3 major health systems here in Central Florida. So again, you take a look at these things, and they tend to move along, and you forget, what is it? We didn't always have just 3 systems. We used to have about 21 independent hospitals in the Central Florida area. And they came together in networks for a number of reasons, and we'll look at what those are today. Additionally, physicians. We had, the combination now of the PAF into Orlando Health. We had Associated come with JSA and the DaVita. Those are just examples. You all know that there are other groups and others that have come together from a physician standpoint as well. And then, least we forget, insurance plans. I don't know who here may be aware, but in Brevard County, you have 4 hospitals that have their own insurance plan. Here again, they've come together and formed a very powerful group, and that insurance plan, now partially owned by Florida Hospital, moved into Volusia County, and now will be moving into Central Florida and probably down into the Tampa area. So again, you have the power of these networks. So this is not a new concept. And then also the blood bank. Anybody remember, I don't even remember the old name. Was it Central Florida Blood Bank? And then it became something else, and now it's One Blood. I don't know. I just know I give blood, and whatever the name is on it that day, I get my little mini physical at the same time. So, okay. So today we're going to have a Blue Book exam. I didn't leave them on the table, but I am going to challenge you to see if a little bit later we have a slide come up. You will see a full network that's been in operation for over 10 years. It's a unique network. Some of you, I would say probably very few of you will be able to answer the question. So the challenge as we go through is see if you can figure it out. I'm going to give you some very definitive numbers on this as you go, but I'm not going to tell you the answer until the end. All right, everybody familiar with the triple aim? Or should I go ahead and explain? Let me give you a little history. The Institute for Health Improvement in Cambridge, Massachusetts, Don Berwick, physician, pediatrician, who developed the IHI, and in the process got together with Dr. John Whittington and some others to come up with a concept that said, what do we want to see in this country? And the answer was, we want to see the triple aim. We want to see population health. In other words, we want to see a healthier population, which presupposes that we're going to get out there in front and we're going to do some prevention and work to do something before the person actually gets sick. How do we maintain and encourage the population health on the front end? The second piece is patient experience. Patient experience from the standpoint of quality, and I don't know whether you saw it, but just yesterday or this week, I think it was Monday or Tuesday, they've come out with the quality indicators now for physician practices, so we can have an idea. There's about a 10-page list of things that are going to be used for measuring quality. But if you look at the fact that it's quality, it's satisfaction, what is it that the patient experiences and how do we improve that experience? And that's where networks are going to be very, very important as well. And then the lower cost of care. I didn't say this. Actually, somebody from the state of Florida said it on a panel for Blue Cross probably about 3 years ago when he said to a large population at a hotel down on I Drive, the Affordable Care Act is probably the most misnamed piece of legislation ever passed. Because the thing it doesn't do at all, as we're seeing, is it doesn't affect affordability of care. But as we're going to see, there's opportunities here as well in some of the new things that are coming out from a standpoint of lowering the cost of care. So let's take a look at each one of those three elements of the triple aim. The first one, again, patient experience. Patient experience, when you look at a network, you have the ability through leveraging your network, through using the various services. The first thing is educating patients. It gives you a chance, if you network around a particular disease, if you network around a particular geographic area, you have the ability to educate your patients, to provide them information around a particular disease process, around the particular area or focus. As you'll see, we do a lot of work in Seminole County in the area of the uninsured, so we have a chance to do education around that, focused on where the need is greatest and supported by a network. Empowering self-management. That's the one big piece, as we all know. We know what we should be eating, we know what we should be doing from an exercise and nutrition standpoint, and we hear that at every MOROF meeting. There's always some good information to come out. But the question is, do we embrace it and do we actually do it? So we want to see everybody in the chair after the meeting, and we want to see everybody waiting for their purchase of their the youth antioxidant tomorrow. Connecting patients and healthcare professionals. If you network and you have the opportunity, one, if it's a geographic network, you have the opportunity then to serve the population and make it more convenient to get to your service. And at the same time, professionals themselves, by working within a network, have an opportunity, and we'll talk about a particular network, but they have an opportunity to interchange and possibly to provide education within that network as well. You know, we have a medical school here locally. How do we provide the expertise out into the network? It's one of the things that we're looking at. How do we begin to provide that? And here with MOROF, and unfortunately Jeff's not here this morning with us, but the whole education opportunity for physicians is a wonderful opportunity. Promoting disease outcome transparency. Here again, if you have a network, you have the ability for common education materials and education to be put out on the network so that people are aware of what are the implications of the disease, and if you're working in the disease from the standpoint of diagnosis and early identification all the way through treatment, how is it that you can consistently deliver common education messages? The research has shown that every time that we change the setting for health, for the service that's being received, the tendency is to receive a whole different set of educational materials. So what happens, and this was an example at the Florida Healthcare Coalition meeting a few years ago, where a gentleman came in and said, you know, I went to the emergency department and I was given this set of instructions by the emergency department of what I should do afterward. So they said, go see your doctor. So the next day or two, I got to see the doctor, and the doctor said, no, ignore that. Here are the instructions you need. Then I went out, and they said, well, you need this therapy. I went to the therapy. They said, no, forget that. These are the instructions. And what happens is we're making people relearn all the way along. The idea here, and we're beginning to bring this up in a Brevard County Health Advisory Group, is let's work on the network concept of having consistent education that builds and reinforces no matter where it's provided. So let's look at population health. The first thing is it does give you an opportunity to encourage professional education. As you'll hear, we're working right now with a group of 10 physicians at the University of Florida on a particular concept. And this concept involves not only patient education, but in this case, physician and provider education as well, providing a more in-depth knowledge of a particular disease state, so it's professional education at the same time as it's consumer education. The individual's needs. The beauty of a network is that you begin to break down the silos. So you're looking at it instead, a good network puts the patient at the center, and you're looking at bringing all of the services together around that particular patient. So it's not unusual to look at taking a network, a large area network, and breaking it into smaller networks around the individual patient areas. So again, it makes it convenient and more accessible for care, and you individualize what it is that they're receiving in terms of education. And then large-scale clinical trials. If you bring together a large group of physicians and other healthcare professionals around a particular disease, again, as we were saying, it gives you a great opportunity to do clinical studies as well within that population. So for a lot of reasons, the same thing that we look for networks today ourselves, we look at networks, look at what networks have been able to do in television for years. They can go ahead and they can provide the wherewithal and the means to pull together resources to be shared on a large scale, and at the same time, something that one individual, let's say a TV station, would not itself be able to provide. So networks also allow us to leverage a great deal. Let me give an example of number 3 in population in this triple aim. This is actually network numbers. For this particular disease, the annual cost per patient in the US is $15,000. So if you look at a population, and the population we're looking at is 10,000 is the population for this particular network. At 15,000, we're talking about $150 million cost to a payer every year. Now, if you look at it with the network, the actual cost drops because this network has been able to find a way to reduce by 7 to 7.5% the cost of maintaining each patient on an annual basis. So now you're down to $138 million or an $11 million savings. Now, let's take a look at what it takes to do this. To do this cost $3 million. So you'll see I have a hat at the door on your way out. Let's get it started. But I only need to find $3 million. But if you look at the ROI, and then it's $1,250,000 every year to keep it going. But if you look at that, look at the ROI from a savings of $11,250,000, and is it worth that? Plus the fact that you're improving patient care at the same time. So this is an example of how we can actually reduce the cost of care by networking and standardizing across a disease state. Now, patient outcomes also improve. This particular one has had a substantial reduction in hip fractures, a very large reduction in hip fractures because patients are being properly educated, trained, there's a rehab involved, fewer disease complications, and these are numbers from an existing network and also a network that has now formed in the state of California in the same model. And also, they're seeing reduced inpatient admissions for this particular disease state. Now, I mentioned before that caregiver education is an opportunity. And one of the things is that as you build a network around a particular disease, you have the ability then to focus on the professional education and to bring up the level of that education because you're all dealing with the same thing. How many of you heard or experienced yourself that the more volume that somebody does, let's say a surgeon does, generally the outcomes are going to improve, right? And we unfortunately saw the opposite effect happen in Palm Beach, for those of you familiar with this, where they've closed down I think it was a pediatric cardiac program in the last month or two because of very poor outcomes. And it was a startup program, the numbers were not there, and the expertise was not there over time, and as a result, they had some very bad outcomes. So in this particular case, what we want to do is encourage better outcomes. The certification of the healthcare professionals actually doing the treatment. That's another one that you can do because you can bring them together. You can bring up the quality and the certification or specialization in this because you're doing a high volume. There's an opportunity for collaboration across disciplines. Again, if you look at the fact that instead of having this program over here and this program here, if you begin to network those, the overall knowledge, you're actually leveraging knowledge across the network. And then, well, as I say, shared knowledge and expertise across the network, and also referral paths. what happens again is you can now refer individuals within the network and know, again, we talked about common education across that, and there's a gain because of just the volume alone that's going to be going through a particular network. Patient engagement. Remember, that's one of the things that we want to do as well. We know what we need to do, but are we doing it? So this is a quote from one of the physician directors of this particular program, this particular network, who says, you know, instead of just being passengers, patients are co-pilots. It's participatory medicine. We are able to engage the patients. And in this particular piece, this network has, of the 5 elements in it that we're going to just take a look at, of those 5 elements, patient participation is an important part. And if you can get your patients, again, engaged and involved in the education and the learning process and then in their care treatment alone, then you're far better off than if you're doing something for someone and they're expecting you to have it done. I think it was, trying to think whether it was Jeff or Paul, one of the healthcare futurists who said, you know, we are living today what we created. Over the last 30, 40 years, people have done what they wanted to do. They ate what they wanted. They didn't exercise. They said, hey, if anything goes wrong, I can take a pill or I go to the hospital and they fix it. And so we're literally living the result of that, and only now are beginning to realize that we have a part in this and that we have to be actively engaged in our own health care, and that this is an opportunity then, if we can do that, to improve our care, be participatory in our medicine. Here's another quote. Philosophy is the patient, not the physician, is the sun, and we should orbit around the patient. This particular network builds mini networks around geographic areas, so again, all the resources are available to you in the local area. And there's a shared decision-making process. So again, as opposed to one-on-one, you have the benefit of a large variety of healthcare professionals working together. And patients and caregivers learn together too. This is an opportunity because, as we know, especially with some serious diseases, we've got caregivers. They also have the opportunity then to learn in this process and be provided and to be participatory in helping the patient. So you actually look at teaching both the individual, the patient themselves, and the caregiver as well. The other big piece of this is information transfer. And we were talking before about what it costs to start a medical office. I was talking to Celia before breakfast about what it costs to start and the cost of the electronic health records. In the practice that I was working in a few years ago, there was $250,000 to put the system up for about 5 offices. And I know any of you in the EMR field or with practices know the cost and the investment in that. But what it does do is it does help facilitate knowledge sharing across sites. And when you have a network, it's a little bit easier because you know that everybody's going to have to be on the same system. And as we'll see in this particular disease that we're talking about, the network is consistent across the board. It is a proprietary system that ties these practices together and develops the information across the network. So they have basically eliminated the issue that we have, which is $37 billion poured into electronic health records over the years, most of them without the ability under proprietary systems to talk to each other. So now we're going back and trying to put our health information exchange systems in place. Enabling collaboration across a regional network. Again, that's where the information is going to be able to transfer. Your outcome data, it begins to be a lot easier if you know what it is that you're focusing on for outcome measures, and you can pull that all together because you're on a common information exchange. Now, the other thing is an improved care continuum as well. We've talked somewhat about the financial value, but also what's the value to the patient themselves? Well, the earlier diagnosis, you want to get a patient into the network as soon as possible. We've just finished a study of the most successful characteristics, and there are 4 of them, in health networks and systems across the country. And I'm talking about, how many are familiar with CareMore in the Southwest U.S.? Started out as a medical clinic and then moved into a network model, a health plan. And then if you look at other networks similarly across the country that have formed that have been very successful, they have some characteristics. And those 4 characteristics are: 1, early identification of people at risk and stratification of those individuals. Where are they in the risk stratification? Are they high risk, rising risk, or low risk? So early identification is one characteristic of any really good network or any good model like this. The second characteristic is care plan. How do we get them into a plan? How do we build a roadmap so that we know where they are today, and how do we either keep them low risk, or do we address the rising risk, especially before organ damage, if you're talking about diabetes, or what do we do to manage their ongoing chronic condition once they are fully blown with that? The third characteristic is patient education and engagement, just as we were talking about before. And the fourth general component, and there's no study on this, I'll just share with you again, looking at programs across the country, the fourth characteristic is home maintenance. It's keeping individuals healthy at home, or as a Boston physician said a few years ago, it's the space between that we have to manage, the space between the clinical interactions with the physician or the clinical system. And again, here, a network allows you to leverage the resources to accomplish that, whether that's home monitoring, whether it is routine home calls, whatever the device is, or the system designed to keep an eye on these individuals so we keep them on a steady plane between clinical interactions. So early diagnosis is very important. Obviously, then treatment occurs sooner. And if you have established transfer, if you know that this is what occurs, the beauty of a network, again, is the system and a process. And if you know that a patient gets to this point, whether that's blood sugar or whether it's some other indicator, and you know that that's when action takes place. You may have heard me mention before Satellite Beach Fire Department. They monitor about 25 or 30 patients on a daily basis in their community paramedicine program, and they predetermine with the patient's physician that here's the range, here's the warning sign. So when that patient suddenly shows a weight gain of 3 pounds on the wireless scale and the fire department shows up in the morning and they're looking and they're going, okay, this is one that we need to get on board. The community paramedic calls, goes out to see the patient or refers them or takes them to the doctors. So again, here's an example of an early warning system that we have. And then the continuing the support around the condition-focused or similar health issues. Again, this is a model built around a particular disease, and so unlike those that are, or everybody trying independently to address it, this is a networked model around that disease, and so there's a greater gain and ability to provide the continuous support around that particular health issue. Now, there are some new networks forming. We talked a lot about networks this morning. Let's take a look very quickly at a few of them. The East Central Florida Cancer Control Collaborative. This formed about 3 years ago. It includes 7 counties. It's Orange, Osceola, Seminole, Brevard, Lake, Sumter, and Marion counties. This network is designed to assist organizations in the area of cancer prevention, particularly what we call 9 sites of care, sites being types of cancer. And this particular network is focused now on 3, lung cancer, HPV, and of course colorectal. So that's the focus, and the reason is because in looking at this and examining it from a network approach, we said, okay, here are the 3 cancers that looking back 10 years and looking at the incidence across these 7 counties, these are the 3 that are either increasing or had been decreasing and had a sudden uptick on the graph in the last year or 2. In this particular one, again, we focus on prevention, treatment, and ultimately survivorship support as well for cancer patients. So there's an example. Common disease, even though it may be different sites, and there's a tremendous amount of exchange. Even this morning, a librarian from a library in the National Forest in Marion County inquired and said, I'd like to have somebody come out and speak on this particular aspect of cancer prevention. In the car, I was able to connect them with somebody at the Health Alliance in Marion County, and they're going to go ahead and be presenting on cancer in this little library in the middle of nowhere. So, but again, we have a network and we have the resources. HealthLink is the system of care. For about 7 or 8 years, Seminole County government has funded a network of services for individuals. It started out and really was until 2015, I call it the SICK network, because if you were uninsured in Seminole County, you could go to this network and they would just take care of you when you got sick. We've now connected this to the health department mobile screening unit in Seminole County so that when we identify early suspicious signs during a screening, we can go ahead and take those individuals with positive results, bring them right into care at Shepherd's Hope or into one of the federally qualified health clinics that participate with us up there. And oh, by the way, we're now adding chronic disease education support groups as well. So we're really looking at this as a continuum of service, all networked, all networked, actually using a network that allows us to also see what else that person has used. We talk about homelessness contributing to poor health. We know if these individuals are homeless or not because we're linked in to the network to allow us to look at what other services that person may be getting or may need, which allows us to go out and trigger that information as well. So we have a robust health information system and a prescription assistance program that last year generated $3 million in free medications to patients that otherwise wouldn't have had them in Seminole County. So there's an example, again, of another local network. The other one is HealthSpan. I've mentioned that at a few of these meetings. HealthSpan is really looking at coordinating early chronic disease support for medical practices. And in this particular case, it looks very much at those practices that are at some financial risk and finds ways that we can reduce the cost of that risk to the practice, which both enhances the patient care and also enhances the financial performance of that particular practice. All right, here we go. This is a diagram of the existing network that we wanted to talk about today. And it provides you, as you can see, with optimum quality of life. It looks at the different aspects in the green or the center or the network's heart. There's education, there's transparency, regional support. Now is your chance, okay? I don't have a prize. I should have brought a chocolate bar. But who would like to figure out what network this is? What disease? Let's put it that way, and then I'll give it to you if you can get the disease. No? 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 I'm going to go ahead and give it to you, okay, in the interest of time, because Chuck's watching this watch. Parkinson's disease, okay? Next to Alzheimer's, and it's a major issue, and what it is Parkinson Net. How many of you have heard of Parkinson Net? Okay, Parkinson Net was developed and has been operating for 10 years in the Netherlands. And so we're now working with the Netherlands, with the Research Institute and Hospital and Health System there. We've tied in one of the 26 U.S. Centers of Excellence for Parkinson's disease that happens to sit at the Institute for Neurorestoration at the University of Florida. And there's 3 health councils and the university and overseas working on putting this into Central Florida. And as I say, I only need $3 million to get it done. So, but we've put together a proposal, and we're beginning to work through shopping that to major payers, because you saw the ROI on that. Those were actual numbers for Parkinson's disease. So we believe we may be able to get that here. They've been trying for 8 years to bring it to the University of Florida, and now they've recognized that on a larger scale we may be able to bring it here. Now what makes it this exciting is not only the fact that I'm learning Dutch as they're teaching me. Their English is much better than my Dutch, as I told them, but they said, well, you'll be speaking Dutch by the time you're finished. But more than that, probably, is the fact that my first question to them was, okay, this is wonderful. We do, incidentally, have 10,000 individuals, more than 10,000 in our area that have Parkinson's disease. Okay, this is terrific. But is there a concept here that could take that network and leverage it for other diseases? And somebody mentioned diabetes, okay, COPD, anything like that. What we learn from this model and how it's applied, we can now apply to other diseases as well, chronic diseases, and of course that's where we're headed. So what can you do to promote networked care? The first thing is look at strengthening your own market position for your practice by forming partnerships and joint ventures. Again, go back to the hospitals. I'm telling you, I mean, there was a question whether South Seminole Hospital in 85, 86, it was brand new, whether it was going to survive. I had 2 empty medical office buildings. I had really no patients, no primary care physicians, no health plan. And what we recognized is there was gain in networking. So 4 of us met at a little restaurant in Longwood, and again, 18 months later, $30 million sale that came about. And you know, we were talking about real estate before. I should have gotten a commission on that. I'd be in Hawaii right now. But the concept was we had to network, and we recognized on the for-profit side that I worked for that if we did not have a network around a city, it made no sense. And so we were able to take this one hospital and offload it to Orlando Health. And similarly, in other markets across the country, the company was Health Trust. We recognized we had to have a network to survive and be successful. So there again is a concept of network. So strengthening the partnerships. Streamlining care by bringing your partners to facilitate coordinated services across different sites. If we're very successful, as we talked about before, in increasing and improving outcomes by volume, then doesn't it make sense for us to leverage across networks the knowledge and the tools so that we do a better job of learning and using and implementing what we learn. Other organizations that may have common conditions, and you can begin again to look at joint network and support and education across that. And then established networks, again, leveraging. I've met with in fact, I saw him again yesterday, one of the accountants that works for a very large accounting firm here in Central Florida that does accounting for large medical groups. And we've had this discussion. We've said, look, rather than reinvent the wheel for every particular practice, let's find out works. There's one group that's looking at social workers for all their offices. Well, rather than do that, why don't we pull together a core group of a few core care managers and leverage that and make them available to multiple practices, which reduces the cost, and we can put them geographically out in the community where they can do telephonic or visits, as the case may be with the patient. Makes a lot more sense than replicating and duplicating across the board. So, talk to us if you'd like to join a network or create one. We mentioned this morning HealthLink. If you're involved in providing services to the uninsured or to Medicaid patients in Seminole County, we probably already know about you. HealthSpan, coordinated chronic care, it's going to be focusing on two areas. One is, again, ways to save practices money and to leverage and grow services focused on coordinated chronic care. We're also in the process of signing agreements with organizations that wish to market their services to the practices that come on board for HealthSpan. East Central Florida Cancer Care Collaborative, if you're involved in cancer delivery in any way, shape, or form, and incidentally, there's no barrier, any of these three networks, there's no charge involved to a medical practice to get involved in this. And then Parkinson Net, and again, that's under development, and our hope is that we'll see that soon. The one that's not on here is a very unique network that we're also in the process of forming in Brevard County. It's too early to share with you other than the fact that the cost of a health insurance plan under this particular model with no deductibles and no copays is $59 a month for an employee, $59 for the employer. It's called a multi-share. It is acceptable under mandatory enrollment in health care. It's a little early to, and that's why I didn't put it up here, but we're hoping very soon, we're in the process right now of contracting to put the network into Brevard County. So that's a bit of a different network. It's not disease focused, it's literally a health program network that we hope to bring to the community as well. We hope that we'll hear from you and talk about how we can create some additional networks and gain the benefits that I've shared with you this morning. Okay, thank you. Any questions?
This is all really wonderful once somebody gets sick.
Okay.
But what do we do to prevent people from getting sick? That's not the focus anymore, and that really needs to be the focus of our healthcare system. In China, each village used to have a healthcare practitioner, and he got a stipend from every family until a member of that family got sick, and then he no longer received the stipend from that family until they were well again. So his focus was on preventing them from getting sick. They had regular checkups where they came in and got diagnosed and got an acupuncture treatment or some herbs or something like that. And that really needs to be the focus of our healthcare system. This is wonderful.
Oh, no. I agree, and I'll tell you, and I may not have put enough in there, but if you look at these networks, they all have a preventive component. Remember the 4 components: early identification and access to services or stratification. In there is a prevention component as well. These networks, for example, the HealthSpan network, we are going to be bringing to you the chronic disease programs from Stanford University in diabetes and chronic disease management. Now, again, that's for individuals who already have it. But I did mention to you in HealthLink, where we've just recently signed an agreement with the health department so that anyone scanned in the community who is presumably healthy or believes they are and is identified as having a positive risk factor will be referred into the system. And while they do not get ongoing care from Shepherd's Hope, that's an episodic approach to individuals. But if you have Medicaid or are uninsured and end up in True Health or Orange Blossom Health, federally qualified health clinics, those are patient-centered medical homes. So again, they're looking at prevention to avoid having you go from low risk to rising risk up to high risk. So there are components, but I should add and enhance the component.
Yes, Celia.
Ken, do all of the services or any of the services span this way? There's lots of reference to Seminole County, and does it matter where the provider is or the person, the client? resides, their physical address?
No, actually, HealthSpan, we're actually talking to people in Lake County and Marion County about being part of HealthSpan. HealthSpan has no geographic boundaries. HealthLink is Seminole County specific because it's funded by Seminole County government. For those of you who know, like today, we're having a board meeting of the Primary Care Access Network, or PCAN in Orange County. PCAN serves that function for Orange County. And in Seminole County, the answer is HealthLink is an equivalent. So it's serving those individuals who otherwise would not probably have access to care. So that particular network is a geographic focused network.
Last week, you and I were both exposed to the results or the findings for the poor performance of the state of Florida in returning hospital visits. So I'm not going to make an endemic sort of statement towards that, but it became clear in the presentation at least that some form of better communication as they exited the hospital is clearly necessary. So in connection with even the prevention side or otherwise, what do you see that? And then the second area that I'm concerned about is, you know, the span of families in, you know, you could have a drug-infected son or daughter, you could have an elderly patient for which the caregiver takes care of, and I like your orientation towards caring for the caregivers or informing them better. So it's not a question directly, but if you could comment on the hospital stays and how those could be reduced, and then also the extended family sort of involvement in a practice or a network.
Great. Let me, well, we'll do them in that order too. It's so interesting that you should bring that up because as a result of the meeting, and for those who were not there, CMS has identified that in our community, we rank much higher, and this is not one we want to be higher in terms of the numbers of hospital readmissions. Two of the health systems or small hospitals in the country that are in the top 5 for the worst readmission rates are in Central Florida. If you want to know what they are, I better tell you later as opposed to in the general sense. But, and so something has to be done. And what's happened is CMS has formed a collaboration or coalition that will be meeting on a monthly basis in Maitland now. It's an open meeting. I've already invited some other people to attend. And it's looking at how do we go ahead and look at the run charts, how do we look at the fishbone diagrams where we can see the root causes for some of these problems and address those. Well, one of the issues that we identified very quickly, and it was with the help of somebody in this room, was the fact that on the inpatient side, the hospitalists have to try and make a bridge when they've got a patient in the hospital back out for that individual, support that transition from the hospitalization out to the community. And the hospitals generally get blamed for these return, and yet they have little control over that because they're trying, in this particular case, the hospital group is doing the best they can. They call the primary care physician, here's your patient, get them in to see practice, so get them into the office. And then the primary care practices, if there's one in the room, they're just crammed with volume trying to handle everything. As we know, we have a physician shortage. So what we decided in a discussion the other day is we need to find an interim. Somebody that can basically go home, make a home visit to this individual, make sure that they're stable in the home until they get a chance to see their primary care physician. And yesterday I actually found out an organization locally who's now doing that already. So I will be sharing that with both the inpatient group and with the family practices and primary care practices. And they're doing it, the biggest issue there, and I know this firsthand having used to recruit and set up physician practices, the issue is the fact that, oh, wait a minute, if I give my patient to this group, will I see them back again? And so this effort is to make sure that there's no concern that that patient's not going to be, switched doctors in the process. So there is an answer, and it is that transition period managing, and Medicare actually reimburses for transition. So there is an effort and there's a financial way to do that, to accomplish that. And that'll be something we'll be looking at expanding and growing because I know that's going to come up at that next CMS meeting. In terms of caregiver education, if you can get the caregivers engaged at the same time, let me give you an example of what's happening in Osceola County. As a result of the Satellite Beach Fire Department model, we took the attorneys from Osceola County over and we created a program called Phone to Home that's operating there. Here's how Phone to Home works, and there's a piece of it related to caregivers. That's what I want to get to. But in Phone to Home in Osceola County, when EMS arrives at your home, on their tablet, they have 3 options for you. Option 1 is, I want to be transported to the hospital. Off you go. Option 2, I refuse transport. And option 3 is, connect me to services in the community. And that's Phone to Home. So what happens is if you check that off, you opt in, the call report from the fire rescue in Osceola County then goes over to the health department where Kim gets the report, looks at it, says, 5 times EMS has rolled on this same address this year. Every one of them, blood sugar issues for diabetic, every time the blood sugar issue had been settled by the time EMS got there and the ride didn't happen to the hospital, which means that the taxpayers of Osceola County just paid $750 times 5 because there's no billing source for that, so it's costing the county. And the county has to buy additional units because they're rolling on these refusals. Now what happens is then Kim picks up the phone and she says, you know what, there is a diabetes education program for you and your caregiver in your home to help you both understand how to manage your blood sugar, what to look for, what are the early signs, so you don't have to be calling 911 all the time. So what we're doing is connecting, and we're in the process of discussing this with Dr. Todd Husty for Seminole and the fire chief for Orange County, and putting similar programs in place with the focus of not only helping reduce the inappropriate or unnecessary use of the emergency system, but also to provide the ability then to do that caregiver education at the same time.
This is more of an observation than a question, but a family member, an elderly family member of ours, was diagnosed with Parkinson's disease, as it turned out incorrectly, but not before she had started to make decisions about going into managed care, about disposing of her car, and things like that. Ultimately, it was discovered to be a drug interaction. She had gone to multiple different doctors, got multiple prescriptions for this, for that, the other, and the whole result of it was this toxic soup, which gave her a tremor, rendered her almost unable to walk, certainly unable to drive. And once that was discovered, she was able to detox, and a few months later she was back to driving, walking her dog, and functioning normally. It seems to me that these kind of networks, if they are observant, can avoid situations like that.
I'm going to suggest the same thing. If you deal with this all the time and you know Parkinson's, then you can probably rule out. For example, the program in University of Florida is quite impressive. We were in there looking at swallow test that they were doing. The result of this, they've actually developed a device that assists in that process that is now sold all over the U.S. That was developed at the University of Florida at that program. But you've got in one location there tremendous amount of expertise. When I looked at it the first time, I thought, okay, well, this is great, but how do we replicate that? Yes, there's a University of Florida building down at Medical City. Maybe we can find a way, but that's not it. That is a center that does the two things we talked about. It does early assessment and it does the care plan, and then patients are managed in the community by a community network. So that's why, again, Parkinson Net is such a great example for us, because if we can get it here and set it up that way, the management does not require you to constantly be commuting up to Gainesville or somewhere else. Literally, once you're evaluated, there's periodic checks, but pretty much you're managed then by individuals, by rehab, physical, occupational therapy. It's very much a dispersed, multidisciplinary approach. But you have that management where you are, so you're not inconvenienced and having to travel all the time. And you have the benefit of advanced education that's shared across the network. There's TV, patient television, education programs. There's support groups online. Now they're into dance therapy. You will see up there pictures. They're opening dance groups that use dancing to help. There's an art group. The art all over the center is actually done with art by patients who have found ways to begin to paint as a way to impact the movement and issues that they have. So pretty impressive. And I think, again, a good model of, yes, ruling out those that are maybe polypharmacy.
I think we have time for one more question here in the back.
Hi. This sounds really good, and I like everything I'm hearing here, but as an insurance agent, as a health insurance agent, all this has to be paid for by an insurance company. We have a lot of managed care companies and referrals and authorizations. How is this all fitting together, these networks fitting together with that? Like, I don't know of an insurance company that I represent that would pay for dance therapy or anything like that. And also, could you talk more about multi-share?
Sure. Let's talk about the dance therapy. That is something that they're doing. It's not a paid function, but they're finding that if patients can come together in their geographic area and do these things together, it helps them. Sure, there's a little bit of a cost. It's related to patient education and self-maintenance. But if you look at the statistics, and I used to own a health insurance agency, so we're speaking commonly, and I understand that. If you look at the statistics and you look at the ROI on an investment of $1.5 million or $1.25 million per year, with an $11 million delta in terms of the cost of care, if you're responsible for that population of Parkinson, you can see where it makes tremendous financial sense to the health insurance plans. And remember, part of that is reduced hospitalizations, and you know that's where the real hit occurs. Now, one of the first things in our discussions with Parkinson Net is find a payer. So we're in that process right now of looking for who is the payer that makes sense. And even though we look at 27 counties as a pilot location, how quickly maybe we see Parkinson Net across the entire state of Florida. That's the goal ultimately, to do that. And if a health plan, obviously as they are, for many of them, not necessarily some of the Medicaid plans, but for the larger picture are statewide, so they can look at numbers far larger than 10,000 that they're already responsible for. So that's the one piece, and now I'm sorry, short term, what was the second one? Multi-share, yeah. Yeah, a multi-share program is designed as a concept that takes multiple sources of funds to put together to manage a program. So in this particular case, you have the employee paying, you have the employer paying, and you have other payers. Now, who might those payers be? One of those payers may very well be the hospital. We've already had meetings with the CFOs of all the health systems in 4 counties because they recognize that under community benefits, there are 7 categories they have to fund at a range of between 2 and 7% of their bottom line. So if you take a Florida hospital with a $4 billion bottom line and take between 2 and 7% of that, you have a lot of money to work with. Most of that money goes into offsetting their losses on Medicaid, so it's money from the left pocket over to the right pocket, okay? But there are opportunities for them. There's charity care and so forth that they can lower if they can get more insurance. So you will see this product go very rapidly into small employers who can no longer afford health insurance, because now it's $59 per employee per month is all they have to pay for small employers. So it's extraordinarily powerful in that regard, and then you will also see large self-funded climb on board as well based on the experience of the program. Again, it's very unique. It's been in the country for 15 years. And it's got the blessing of CMS to be expanded, and again, it became one of the only program of its kind in the U.S. that was approved under the Affordable Care Act. So we expect to see it expand fairly rapidly. Okay.
Thank you so much, Ken. You're definitely a wealth of knowledge. And we will be continuing the discussion on our LinkedIn page. If you have any other questions that come up, or if you want to participate in that, we do encourage. We have a LinkedIn open group for MOROF, as well as a closed group for the members, and lots of discussions can go on in that regard as well. Thank you so much again for attending.